Now, the next presenter, Kate Okrasinski, she's also a wanderer. She comes from the US. She spent time in Amsterdam doing research, and she's going to talk about patient perspectives in design. Thank you.
Thank you very much. First and foremost, I really want to thank everybody here for the opportunity to come and present amongst this community. It's been an amazing opportunity for me. And I'm here to present my master's research in inpatient rehabilitation and patient participation. But since it is Friday and almost 4 o'clock, I would actually ask you guys to present or to participate with me if you don't mind playing along a little bit. Do you guys mind all coming to the front of your chairs and just sticking your hands up in the air, just one finger up in the air for me right now? There we go. So far, so good. And do you mind drawing a circle for me in a clockwise direction? So from noon to 1 to 2 to 3. Okay, so once you got that going, I got a lot. There we go. Nice and easy. Okay, so I want you to keep that circle going. And I want you to lower that circle now down to the level of the table. Now you started drawing a circle in the clockwise direction, but notice which direction it's currently spinning. Counterclockwise, right? Now your finger was still going in the same direction. I'm pretty sure I saw all of that. But what changed? Your perspective, right? Where you're looking at the problem. And that's what I'm here to do today, is to help kind of present the other perspective. And if you are still challenged by this little question, we can work on that in the coffee break. I'll walk you through it one more time. All right, so, I mean, this Congress has been fantastic. We've brought together so many different schools of thought, so many different opportunities. And there's been an enormous amount of empirical research, post-occupancy evaluations. In fact, my colleagues from the Netherlands just presented the power of those. We've discussed a lot about user surveys, user questionnaires, focus groups, but also staff interpretations of patients' needs. This is particularly key in disability research, where quite often people with disabilities are not approached as to their perspective. They're often left out of this engagement and out of this conversation, where people will look to the staff for their interpretations. Very few people out there in the literature and in the research today actually ask the patient, how would you do it? How would you design your own care environment? And that's exactly what I did in my master's thesis as a transdisciplinary researcher in global health. I'm focused on participation in research and how we can engage meaningfully with our clients, with our users. And this grand assumption in participation research is that the user is the expert in the environment, and that we want to capture their experience and understand that their perspective. We want to identify what influences them from their current condition, and then collaboratively innovate with them based on their needs, their ideas, because they themselves are the experts, and they often have an idea about how to solve their own problems. So let me move now to the research I did on the inpatient rehabilitation ward and exploring patient perspectives in the built care environment. My partner was Reata Center for Rehabilitation, a rehabilitation center right in the center of Amsterdam. Now, inpatient rehabilitation is quite unique in and of itself. It's classified as its own unique building type. It's different than an inpatient hospital, where a patient will stay for an average of 5 to 7 days. And it's very different than a nursing home care facility, where a patient is going to stay then for towards the end of their life. Well, inpatient rehabilitation happens somewhere in between, after a catastrophic injury, for example, a spinal cord injury, stroke, muscular disease, cardiac events. And rehabilitation can take a period of weeks, if not months. In fact, the average length of stay of Reata, independent of patient group, was just over 4 months. So this is 4 months in a hospital care setting. And the care goals are also very different in inpatient rehabilitation. First of all, the patients are clinically stable. Despite the fact that they need a lot of attention, they're not sick. They're stable. They're just in a new body. They undergo intensive daily therapies to regain strength and stamina to meet their goals. But their goals are not to return home to a life that they expected or the life that they left before their injury or accident. No, they're trying to return to meaningful roles and activities, assuming that there is going to be some sort of accommodation in their future. I came across this quote from 1988 by Patricia Deegan that I thought was quite poetic and captured rehabilitation as recovering a new sense of self and of purpose within and beyond the limits of disability. So this was my research question. What do patients need and value within the design of inpatient rehabilitation ward, meaning their care environment, and which design strategies emerge from the prioritization of these key needs and values? I was particularly interested in how patients organize space in this new body, and what aspects of the environment influence their experience in this care environment. Now, being trained in transdisciplinary research, I really reached out to a bunch of different fields of research to build my framework. First and foremost, I'm going to start in the middle, in the green circle in architecture, from the Center in Health Design framework, where a design strategy, so a particular choice we make in the care environment, leads to environmental characteristics. For example, the glazing or the facade we use leads to a certain glare environment or noise level based on the tile choices. And from that, there's a certain outcome that has an effect on a human. Well, I'm going to expand bigger and look to environmental psychology then to pull in the unique elements of the human. So there's patient characteristics that are important. For example, your age, your gender, but also your ability or relative disability. Do you have, or are you more vulnerable to stimulation, to temperature, to intensity? And then also, how long are you in that care environment? For example, we can all stand in the kitchen while the smoke alarm is going off and tackle everything, right? But if we were to stand there with nothing that we could do while that fire alarm is blaring in the kitchen, I don't think we'd last very long without going crazy. Well, it's the same kind of thing I'm interested in. What is your ability, and how long before those affect you? And then last, I'm going to dive into the center there within the design strategies. I looked at anthropology and Edward T. Hall with proxemic theory to understand how a patient in a new body just recently suffered from a spinal cord injury, a stroke, maybe with an ability or a disability, how they organize space. Are they able to use the same dimensions for space that we would normally use, or do things become much more sensitive? How is that defined for them? Well, my research timeline was very iterative. It first started with a massive literature review on health, healing, and safety in hospital environments, preliminary interviews just to kind of understand where we stood. I'd spent a lot of time shadowing, actually, in the clinic, not only to learn about rehabilitation, but also to integrate in with the staff and the patients to gain some familiarity and trust. I did a lot of practice interviews, developing my methodology, and a guidance meeting with all the healthcare managers and the physicians to help really understand within the management what they wanted to learn and what they wanted to get out of it. And then I developed this technique called My Ward Design Interviews. And this was based off of research done by Alison Hutton in Australia. She did it with children. But I adapted this idea of co-creation and co-design to work explicitly with people that didn't have the ability to write or to draw. And what we did is we sat down with a big blank piece of paper, and I started with, what's your favorite place? What do you like? What don't you like? Why don't you like it? What would you do to change it? And from there, everyone that entered into the conversation saying, I don't really know about design, I'm not much of a designer, I don't know what it should work like, well, all of a sudden had great ideas, very, very emotive ideas about what they wanted and how we could solve their problems, help them get home, back to their family faster. So as we did this, it was all about co-creation. So I would immediately draw with them, or if they could not draw, I would draw for them so that there was something tangible we discussed. We created together, and there was never an assumption of that I understood them. We negotiated that throughout the entire process. And as we did, we pulled out values, privacy, support, other values that came up in a second. I would put them on a sticky note and stick them aside. And then at the very end, we looked at those And I asked them, do these all cluster together? Where is the break? What can we make of this list? And then to you, what is the most important? Can you put this on a hierarchy? Well, this is what kind of came out with. This was the raw material. It was a bunch of drawings. It was concept maps. Some of my interviews were 10 or 15 pages of these. We just wandered and talked, and we explored what was happening with them and within their care. But what was really quite cool is when we entered into the analysis phase, it was very clear that proxemics was present in their lives. There was a definition of intimate space, meaning that space that was really within them, and also actually with the nurses. It was the only place that they received human contact there and engagement. Personal space was defined for patients as the place that they could comfortably leave something that belonged to them. So in a 4-person bedroom, that was the area that was closed by a curtain. People felt awkward intruding there, so you felt like you could leave a book at the edge of your bed, for example. But in a single-patient bedroom, that was your territory, and you closed the door, and that was your personal space. But notice how those two overlap, because as soon as those curtains are opened in a multiple-patient bedroom, that then turned immediately into social space. So some of the values that are worth highlighting in this presentation. Within intimate space, people really talked about intimate space and how important it was at the beginning of rehabilitation, when they didn't have the strength, they didn't have the stamina yet to move from the bed. They needed things within reach. They didn't want to call and buzz the nurse to ask them to bring their deodorant, which was just on the cart or just inside the closet. There was an element of self-sufficiency. They just wanted to freshen up, and they had to bother somebody else to do almost every minor chore that they could have done themselves. Whereas additionally, lighting and control. If you were in a 4-person bedroom, everyone put a small reading lamp by the headboard in their own designs because they wanted to have that choice. What happened? 10 o'clock, lights out. They wanted to be able to still turn on and still do something and not read by a flashlight. The next things were elements of security and comfort, including a visual connection or an auditory connection to the hallway. There was universal mistrust of the alarm bell system. And they wanted to have something that they could hold on to, something they could back up their story and either make a visual connection with staff or an auditory connection to somebody else to scream for help if something had happened. Now, within personal space, this became a little bit quite interesting as well. Not a single patient I interviewed, and there was 9 of them, had discussed having a solid night's rest since they were admitted. So these patients were here for about 4 months and had not slept entirely through the night, and were asked to get up and do very physically and mentally exhausting rehabilitation during the day, only to desperately pull back and try to find some element of retreat. Privacy, additionally, was just as sensitive. For them, it was 2-dimensional and had 3 components. I do not want to see you. I do not want you to see me. I don't want to hear your private conversations with a doctor or with your loved one in the middle of the night. You deserve to have that to yourself. And I do not want you to hear my private conversations. I don't want to have to ask those questions in front of you. The next is the olfactory. I do not want to smell you, and I sure don't want you to smell me. However, here in a 4-person bedroom or sharing a single bathroom, this is what we were up against. The next is this element of active rest. In fact, everybody in their own designs put in an own table and chairs. They wanted a place where they didn't feel like they were sick. The only place they could sit that was theirs was a bed, but they weren't sick. They wanted to sit down and just relax. They wanted to sit down and do their legal documents. They wanted to sit down, write a couple emails. They wanted a place that was different than a bed to be able to rehabilitate. And this idea of active rest emerged. Between social space, the whole idea of diversity was just paramount. In fact, in my observations, I noticed a lot of people would just take themselves on a walk. Whether it was a wheelchair, in fact, most of the stroke patients couldn't go forward because they didn't have the arm strength yet. So they would take their one good foot and push backwards, and they would take laps around the whole hospital, throughout the administration wing, down the elevator, out to the garden, around and back in, and they just described, I need to move. I need to feel a different temperature on my skin. I need to smell different things in order not to feel trapped. I'm here for so long. The next that was really crushing was the whole idea of bonding and intimacy. I spoke to one woman who was a mother, and this was not the only case, but just the most explicit. And she was, her child was 6 months old when she was admitted to the rehabilitation center. She said, I can only see my child for maybe an hour a day during visiting hours when my child's not asleep, and I've completely lost my connection with her. She was recently sick and came to visit me, and she didn't want anything to do with me. She didn't want to be held by me. She only was reaching for my mother. And this woman was in tears, just crushed by this torment of her trying to rehabilitate, to be a mother, to be back, to be strong, but having lost everything between her newborn baby and herself. And the other is with partners. Patients constantly described craving just a simple opportunity to cuddle. There was no opportunity to mourn your loss of your body or to discover with your partner a new way of intimacy or to even just comfort each other without other people looking in. In fact, I have one picture, and it's going to be in the publication, that describes just 2 chairs in a simple hallway that was right when the administration wing would lock down. And a patient led me there and said, this is my secret spot where me and my husband can talk without people trafficking by and listening in on us. But if we look deeper into these narratives, these really moving elements, you actually see that patients go through 3 phases of rehabilitation, and they need 3 different types of space to support them the most in rehabilitation. The first is this idea of rest and recovery, where you're not sick, but you sure are tired. Your need to gain strength and stamina, and you need intimate space to be very well supportive of your area. But then as you get stronger and you can move from your bed, you need social engagement right outside the door. You need to know what you're getting into. It's going to take you a lot of energy. So you need to know where you're going, what you can predict, and you want to be able to find that. But then as you're about ready to go home, you've been here 4 months, you're turning inwards, and people start realizing, I need now to kind of invest in the concept of what is it going to be like. I need like a test home. I need a way that I can get up, get dressed, get my coffee, not rely on staff unless I really need them because I need to practice. This is me when I go home. I need to do this. How can we support those spaces and those 3 different types of rehabilitation? The next is patients constantly wrestled with this idea of how to protect privacy and also invite participation because, as we said, the goal of rehabilitation is participation in those meaningful roles and activities. So they know that they need to participate, but how can they do so meaningfully while also providing enough time to just rest and recover, to withdraw, to have that, the holistic approach to intimacy, bonding, privacy, autonomy, and rest without being obligated to constantly socially interact, to have choices, to have variety and different frequency of activities. But it wouldn't have been true transdisciplinarity without actually exploring outside perspectives. And as a little teaser for future articles I plan to write and the research I continue, this is the other interactions I had. So patients, we discussed, they almost universally focused, without me guiding them, interestingly enough, on 3 different types of space: intimate space, personal space, social space, almost uniformly. Nurses almost mirrored that, and I believe that's because of their intimate connection with the patients and that shared conversation. Physicians, on the other hand, only tackled personal space. It's about the only area that was important to them, the only thing they really quite cared about. Therapists, on the other hand, occupational therapists, are responsible for that participation and getting people out into social environments, and they threw all of their energy into designing and creating social spaces. This quote just kind of, it means a lot to me, but we shape our buildings, and I believe also who we ask to be involved in shaping our buildings will then shape us and the care we provide. If we don't ask every single user in the building to participate in this question, we might be stuck with the wrong perspective. And in final conclusion, I really want to just send home that message, the power of participation, not only empowerment and what it did for those involved, those interviewees, the patients who said, I don't really know anything about design. But when they walked away, they felt empowered. They felt a part of the solution. the capacity. I had other people tell me that, no, you shouldn't really talk to them because you can't really capture their ideas, or maybe they can't quite communicate with you. No, they can. Everybody knows what they like and what they don't like. You have to start from a common place. The importance of the built environment. Cannot underestimate that enough. The environments we build shape us. They shape the care, they shape the interaction, they shape the hierarchy. And we need to really carefully integrate that built environment with our care to support our patients and our care values. And the last is responsive innovation. How are we going to respond to these needs, intimacy, particularly bonding? How are we going to respond and create with patients unless we know? We need to really focus with them to design their own solutions. And last, I'll leave you with this. Inspiration is earned. You have to create the opportunity to earn it, and sure enough, have a plan to be able to capture it. So thank you.